Hi there, fellow dentists and fellow orthodontists, dentists that want to learn more about orthodontics. Welcome to my channel. This channel is dedicated to all the dentists who love orthodontics or are keen to learn more about orthodontics. So today we'll be learning about orthodontic implant armamentarium. Now this session will be a short one, and if you have not seen the previous sessions, please go back to the older videos. There are, I think, 3 more videos before this. So you'll be learning about the introduction to orthodontic implants, and if you brush up on that, then I think it'll be easier for you to follow this particular video. So today we'll be learning about the armamentarium that you need to place orthodontic implants and a few basic steps to be kept in mind when you're preparing for your orthodontic implant placement. So just imagine today is the day, and today you're gonna place those TADs in the patient's mouth, and the patient is coming today. So you have to plan it beforehand. You know how it is in dentistry. Even though it is a minor surgical procedure, you have to plan everything in advance, and it's a surgical procedure after all, so you have to take a few precautions, and a few measures have to be in place. And if you have a proper protocol and a systematic protocol established in your clinic, it's easier for you and for your staff to continue practicing according to the protocol and give good results every single time. So let's get started. So on the left, what we have is the hand driver for tag placement. On the right, what we see is the motor way of placing the tags. So the right one depends on electronic equipment, but the left, you don't need any special equipment. On the right, what you see is the motor driven, and the instrument or the device that is used for motor driven tag placement is the same that is also used for prosthodontic implant placement. So if you have that in your setup, in your practice, you can use the same, so you don't have to buy an additional instrument for motor-driven tag placement. So on the right, we have 4 pictures. Let's learn about the pictures in the clockwise direction. Picture number 1, we can see the image of a hand driver. Now there are 2 parts of the hand driver. One is the handle, the other is the shaft. Over here, the handle is blue in color. As the name suggests, it is the handle. So it's a part of the hand driver that will be in your palm when you place the TAD in position. This is where you'll hold the driver in position. The other part is the shaft. Now, in picture number 2, you can appreciate the shaft part of the hand driver. Now, why is this part important? This part is the working end of the hand driver. That is why it's important. Now, at the working end of the hand driver, you can also see a small opening, and this opening is where the head of your TAD will be located. So this is where the TAD is held in position while you are placing the TAD in the patient's mouth. Now, there are 2 ways of keeping the head of the TAD in the driver. One is the frictional method, another one is mechanical method. Now, this over here is a friction method of holding the TAD head in position. Now, why is it friction method? Because there is no lock and bolt involved in fixing the head in the driver, in the sense that there is no special lock and key involved in stabilizing the TAD in the driver while you're placing it. Now, this kind of hold is better than the mechanical kind of hold. Another example where I can give you is, in cases where you use a micromotor for enamel cutting. Say you're using a micromotor to cut a class 1 cavity, and it's a small cavity, so it's not a gross decay. Some amount of undermining enamel has to be removed. In such cases, you will appreciate that although the micromotor is a good device, it's a strong device, but then because the burr is held in place by the lock, by the small locking system, the mechanical lock that is there, you'll appreciate that when you're cutting cavities in good strong enamel, the burr tends to wobble because the lock and key mechanism involved is a mechanical lock and key, unlike over here, which is the frictional lock and key. So there is no special nut and bolt involved over here, but despite that, it is a much stable grip than which you see in a mechanical grip. Coming to picture number 3. In picture number 3, we can see that the head of the TAD is into its the working end or the driving tip part of the shaft held securely in place. Now there are different lengths of hand drivers available. So when you say different lengths, you're actually not saying that the handle of the driver changes. The handle of the tab remains the same, but it is the shaft that changes. So when you want to use the driver in poorly accessible area, say a more distal anatomic site, say retromolar pad or maxillary tuberosity, or slopes of the palate, maybe even the mid palatal area. In such cases, it can become a little difficult because when you're using a hand driver, the the energy to drive the T.A.D in place depends on your hands. So when an operator places a T.A.D with a hand driver, he also has to place the entire palm and the fingers of the operator have to reach the patient's mouth or on the and even the anatomic side. So when you do that, obviously it is affecting the visual axis. It's also difficult to reach the site of the anatomical site for implant placement. So in such cases, one way to decrease the inconvenience and improve efficacy is to use a shorter shaft. So most drivers are also available with two different lengths of shaft, the long one and the short one. So you can use a shorter shaft also for placing the T.A.D in such areas. There are special T.A.D drivers which are available. They are also hand drivers, but they are slightly different from the driver which you can see in this picture over here. So the speciality about those drivers are, you can call them mini drivers because it is almost maybe you can say it is 1/3 of the hand driver which you're seeing over here. Now why are those drivers special? Because they not only is the shaft short, but even the handle part of the driver is also very short. So it looks like a it looks like a very small a baby hand driver. Now those hand drivers are specially designed to place the T.A.Ds in the mid palatal area. So those T.A.Ds can be easily positioned and angulated because over here you can see in the picture that it's quite a big instrument, so it can impede in reaching poorly accessible areas because of the size factor. So if you have a very small uh, hand driver specialized for mid palatal area or parapalatal area, it becomes more efficient to place the T.A.Ds. Now as far as the grasp is concerned, how do you hold the driver in your hand while you're placing the T.A.D? Well, it's more of a, well, you can't call it a palm grasp, but yes, it's a kind of a palm grasp, but just remember that it is the head of the handle should be in the center of your palm and the rest of your fingers should encircle the handle, the rest of the handle of the driver. We'll be seeing that in the next picture. Now there is a slight modification that lies for the hand drivers. There is a special hand driver which is also called as contra-angle hand driver. Now what we are seeing over here, as far as the manual hand drivers is concerned, always remember the manual hand driver could come in the straight form and in contra-angle form. Now the straight form could be long or it could be short, and we already have learned that the short one is specialized for the mid palatal area and the long one which you can see in the picture on the right. As far as the contra-angle form is concerned, the contra-angle form is also called as top driver. Now why is it special? The reason number one why it's special is because it has an angulation. It is not straight. So it has double angles in the length of the driver. Now, why is it also called top driver? Because at the end of the driver, at the distal end of the driver, you see a screw-like mechanism to drive the T.A.D in place. And now the problem with this is that it is unstable. The contra-angle top driver is unstable, and yeah, you'll be appreciating that in the next slide. Now, what is the advantage and disadvantage of having a manual driver? Well, I'll tell you advantage first. The main advantage of having a manual driver is that it is efficient. It does the work well. It does the work under control. You don't need second benefit, you don't need a special equipment, you don't need to buy anything, any expensive armamentarium. Yes, you have to buy the hand driver. Yes, it has a cost, but you don't have to depend on expensive gadgets. You need repeated maintenance, etc. Advantage number 3. Most of the T.A.Ds can be placed with the help of hand drivers. Most of the T.A.Ds do not need a special motor driver. Usually, it doesn't need special motor driver. Reason number 4, you got excellent control on the T.A.D. You got excellent grip on the T.A.D while you're placing the T.A.D in the anatomic side plant. Problems. What are the problems of using a hand driver? Problem number 1. Well, there are chances that you may not have the exact idea of the amount of force and torque you're applying when you're placing the T.A.D. Because you are obviously you're human, and there is slight possibility of human error. So you don't know exactly how much amount of force are you applying, what is the torque force that you're applying when you're placing the T.A.D. So if you keep that in mind, there is a lesser chance of any error on that side. Problem number 2. Cases wherein you want to place multiple T.A.Ds, and cases where maybe you need to place 4, 5, maybe more than that, then yes, it may take some time to place T.A.Ds with the help of a hand driver. So time factor can be an issue, which is not a big problem, because if you plan in advance and you can do the work slowly. Even if it takes a little more time, it's okay. So overall, a hand driver is a plus plus when compared to a motor driver. In the sense, I would give it a 5 star. On the right, what we can see is a contra-angle torque driver, and we already know that it is actually a type of a hand-driven T.A.D driver. Why is it hand-driven? Because this green part is a rotating nut, which is at the distal end of this hand driver. Now, the specialty about this is that in areas where you cannot reach easily, and we already know when using a hand-driven T.A.D driver, what we need to do is we have to place the entire hand in the patient mouth. It gets inconvenient, it gets uncomfortable. So in all those poorly accessible areas, retina pad and massive tuberosity, maybe slopes of the palatal area, etc. In such cases, it can become difficult. So in such cases, instead of using a hand driver, you can use a modified hand driver, which is over here a torque driver or a contra-angle hand driver. Now, what's the advantage? Well, advantage is accessibility of poorly accessible sites, and we already know which are those sites. What is the disadvantage? Well, disadvantage number 1, it is not that effective. What's the point? What's the point in buying, or the point of buying an instrument which you cannot use very well, right? So imagine you buy this instrument and it's not doing a very good job. So because it is a hand driver, it has to be driven by your hands, and when you're doing that, one hand should be on the green part, rotating it continuously so as to provide the power to make the implant on the working end rotate and screw it in position. Now the problem is that you need to use both the hands, so it's an unstable procedure. It's like the torquing wrench which you use for implant. So but then over there you're just torquing the device, parts of the device in position. Over here you're placing the T.A.D in position. So in such cases, we cannot afford any kind of instability. Problem number 2, if it is a very thick cortical bone, there is a possibility that this T.A.D will stop rotating. It will stop rotating and stop cutting through the bone, and hence it will not even sit into its planned location. So what's the point of buying this driver? It's not doing the job of a manual driver completely, because it is not stable, and we have already learned that the friction grip of the T.A.D is better than the mechanical grip. The kind of grip we are depending over here is a mechanical grip, because it is very similar to that of a micromotor. The T.A.D head is engaged into this device in a lock and key fashion because of the unstable way, the head is held in position, the efficiency of this method is. Now, how do you hold the hand driver in position? You need to hold it in a stable manner, and I borrowed it from this book on orthodontic micro screw implants. And this book is a very good book. Please go through the book if possible. Read it more than once, and every time you go through it, you learn something new about orthodontic implants. Now, over here, you can see that the implant driver is very stable in the palm of the operator, and this is why the hand-driven drivers are more stable than the hybrid or the contra-angle torquing. So on the right over here, we can see the picture of a prosthetic motor for placement of implants. So this picture is from the catalog for prosthetic implants. So it's not exactly an ortho case represented. But then just imagine you're placing a TAD with the help of a motor. If you're doing so, over here you can see that you'll have a handpiece in your hand and you will hold it. What kind of grip will you use to hold the handpiece? The same which we use for placing, for cutting enamel with the help of a air rotor. The same grip will be used. It will be a pen grasp. Now, second thing which you can appreciate is that at the working end of the handpiece there is a burr. This picture is from prosthetic implant catalog. So it is a burr to cut a bone before you place the prosthetic implant. But if it is an ortho case, instead of this cutting burr, what you'll have is a connecting burr. So the burr that will be used in case of an ortho will not actually cut. It will only act as an extension of the head of the implant. Basically, imagine you have a hand driver and instead of a shaft, you are having a connecting burr over here. It is the free end of the shaft which holds the head in place, head of the TAD in place. Similarly, over here also we have the connecting burr, and the free end of the connecting burr is holding the head of the TAD. So you can just compare both of them and you can imagine how a motor driven TAD placement works basically. Now these TAD drivers are also available in two TAD holding grips method. Well, one is the frictional method and the other is a mechanical method, and we already know that the frictional method is better than the mechanical method. And how we had in hand driven TAD placement, even over here we have different lengths of connecting burrs available. So over there we had different lengths of shafts available, and based on that we could, based on the anatomic side, we could select the kind of shaft or the length of the driver that we want. Similarly over here also, based on that we can select different connecting burrs. But in this case the situation is slightly reversed, because over here it is a slender hand piece, so it basically reaches on the sides. So you can use the same hand piece for tuberosity, for retromolar pad, for slopes of the palate, and even mid palatal area. There is usually no problem at all. But what happens when it is a patient with a long face, a dolichocephalic profile, and maybe patient with a mouth breathing problem, a very deep palate? In such cases, it may be difficult to hold the handpiece in ideal position because you will not be able to reach the depth of the vault, palatal vault, and place that, especially in case of mid palatal area. So in such cases, what you need is a slightly modified form. What you need is a longer connecting burr. So if you remember earlier when we placed implants with hand driver, in case of palatal area, we use a shorter shaft because we use the entire hand to place the driver to place the TAD in place. But here the situation is slightly reversed. So when you want to reach such areas, to work more ergonomically without affecting the precision of implant placement, we need a connecting burr of longer length, so as to reach deeper vaults, deeper palatal vaults. So we have compared both the hand-driven and the motor-driven TAD placement. On the left, we can see there's a different parts of the TAD placement, and on the right, we can see the different parts. We already have learned about them, but one thing we have missed out is the kind of drill that is used. So in case of hand-driven TAD placement, we use only one kind of drill, and it is called the pilot drill. Again, that is also an optional thing, you don't have to do it all the time. But in case of motor driven, we have a pre-drill which is required, and along with this, a pilot drill can also be used. First of all, what's the definition of a pre? What's the definition of pilot? Based on Cambridge Dictionary, these are the definitions, some of the definitions available. So if you apply this in orthodontics, what do you learn? Well, pilot drill, as the name, as the word pilot suggests, it will act as a direction, and it will provide a introduction mean of placing the TAD in position. Say you have a self-drilling TAD and you want to place it between the mandibular first premolar and the mandibular second premolar. When you're doing that, you take a small pilot drill and you form a small notch on the cortical bone. The first advantage is that you're removing some amount of soft tissue. Some amount of soft tissue is cleared, so it's easier for the TAD to go in position. Second advantage is that you are removing a very small amount of bone, and basically negligible amount of bone. All you're doing is that you're not even cutting the bone. All you're doing is that you're just forming a notch, kind of a notch or a catch. Now this will help hold the working tip of the TAD when you're screwing the TAD in position. So when you're doing that, when you're positioning the TAD in position, there's a lesser chance of the TAD slipping. If you don't do this pilot drill, then the TAD may slip. So when the TAD slips, you've got lesser control on the TAD. So that's the problem with placing a TAD without using a pilot drill. The other advantage is that it heals very rapidly because a very small amount of bone is removed when we are doing this. When it comes to pre-drill, you're actually removing some amount of bone. In case of pre-drill, a small fissure burr or a small round burr will not be enough. So a slightly bigger amount of burr will be, a bigger size of burr will be required. But of course, make sure that the size of the burr should not be greater than the size of the TAD that you're placing, because if you're doing that, your TAD will be loose in the hole which you have drilled. For pre-drilling burr, just make sure that there is an adequate amount of bone which is removed. In both the cases, irrespective of what kind of drilling that you're using, in both the cases we do need saline irrigation constantly, because we do not want to damage any bone. Constant cooling, simultaneous cooling of the working site will decrease any amount of tissue injury and post-operatory pain and minor swelling that the patient can experience in certain situations. Usually patient does not have any main problem after placing the TAD, but in some occasion, if the procedure takes longer, maybe the bone is very thicker, the cortical bone is more thicker than expected, unlike what it shows on the radiographs, then in that case it may be a. So today is the day, and today you want to place a TAD. What do you do? Irrespective of which company, which brand do you use, just keep in mind that there are a few standard procedures which are there to be followed when you place a TAD. And most manufacturers will give you a guidebook to place TAD, because every TAD will have some additional features, some special features, and the manufacturer will give you a good instruction. So please read the manufacturer's instructions. Don't just ignore them. Please read them, because maybe there are few additional features which have been added to your implant by your manufacturer, and if you don't read them, you'll not know about them, you'll not know how to make the best of those features. And I think it is big disservice which you're doing to yourself, because those instructions are there for your benefit. So if you don't read them, you're not making the most of them. You can just go to any company website and say you're using, over here I'm just giving you an example of Dentorium implants. So if you go to Dentorium website, they will give you a big PDF document on TAD placement, on their products, on their TADs available, different lengths and different diameters and different patterns, etc. So on the right, I've just taken a picture of one of the pages for the steps involved in TAD placement, the steps that they recommend. So what they're recommending is the preparation step, selection of the screw step, perforation of the gingiva, bone preparation, and insertion. So this is how they have classified the different steps for placing that. So you start with planning, then you give the anesthesia on the mucosa, only on the mucosa. So that means they are talking about the topical anesthesia. The third thing they say is selection of the screw. So you have to select the length of the screw and head design. Although they are talking about that over here, I strongly recommend that you do that much before. Basically, keep at least a few um, 2 or 3 tags ready, different lengths and of different patterns. Possible um, change in plan that may be required when you start placing a tag. Maybe something may not work. Maybe you plan some tag placement and that design or that thickness or that length may not seem suitable once you start placing it. Maybe it turns out to be a thinner cortical bone or a thicker cortical bone, or maybe a thicker gingiva than is expected or a thinner mucosa than expected. So based on that, you can modify the tag that you're using. So keep a few extra tags sterilized and ready and next to you. So do the selection process before anesthetizing the anatomic site and keep some extra tags ready in your hands. The next step they are advising is perforation of the gingiva, and we already know that all we need is a pilot drill to just remove some amount of attached gingiva. So they are talking about a punch cut. You can call it a punch cut, you can call it a perforation, depending on which instrument you're using, and this will remove the soft tissue that may speeden up or smoothen out your process. Now the next step is the bone preparation method. This is where you're actually cutting the bone. Now this again can be done with the help of your pre-drill. Okay, so perforation of the cortical bone is done. So perforation of the cortical bone has to be done with the help of your implant if it is a self-drilling burr. So the self-drilling burr itself will perforate through the implant and be positioned in place. Or insertion without pre-drilling, or in case of a TAD that requires pre-drilling. In case of pre-drilling TAD, you have to use your pre-drills, and we already know that the drill diameter should be slightly smaller than that of a TAD so that your TAD is not loose in the location. Next is the insertion. There are 2 ways of inserting, with and without torque control, and we already have learned about the torque driver, and there are also wrenches available to hold the tag in place. But in case of an orthodontic tag, it really does not have any significance, not much of a significance. So your regular drivers, and if you're using a motor driver, that's good enough. You'll have a very good idea on the torque that you're using in case of motor driver. My suggestions to you: start with diagnosis and treatment planning. The day you do a good diagnosis, the same day you can start planning the treatment, work on it, think about it a few times, plan and replan, and once you are sure of all the nooks and corners of this case, you know what you want to do for the patient, how you can help the patient. Now, if you are sure that TAD will help the patient, maybe it will help the patient avoid a surgery, maybe it will help the patient get better results, better control on anchorage, or better intrusion, whatever may be the reason why you're using TAD. Make sure that you know why you're using the TAD. Now, once you know the exact purpose for using TAD in this case, then you will know in which location which will it give you the maximum results. And based on that, you plan the TAD location. Whether is it in the maxilla that you'll use it, or in the mandible, then again, is it in the anterior location it will give the best results, or is it in the posterior? So plan, plan, and plan. You need all your diagnostic records. So anyway, you'll be collecting them before the diagnosis, so you already have them handy. You already have your lateral you already have your OPG, and you already have done the periodontal examination. You already know all these basics, so you already done the diagnosis. So you don't need, usually don't need any additional diagnostics for placing the tags. Now, what does your toolkit look like? Well, your toolkit is a combination of, we already know the armamentarium that you need, this is the driver that you need, and you can use a hand driver or a motor driver. But apart from that, you need your basics. You need your basic diagnostic toolkit, you need your mouth mirror, You need different probes. You need your periodontal probes, your CPITN probes. You need your tweezers, your sterilized gauzes. You need all of them in place. You need good lighting, good angulation of your chair to make sure that you get a direct vision of the anatomic side and not an indirect vision. The other things that you will be needing when you're placing tags is all the diagnostic records. Your lateral cephalogram, OPG should be next to you. You should know the thickness of cortical bone in that area. You should know the angulation of the roots in that area. You need topical anesthetics, so just a lignocaine gel in that area can be applied 5 to 10 minutes before, and then you can start working on that area. Never give a block or any kind of nerve innervation, nerve anesthetization. You can give infiltration, that's okay, but don't give anything that is more of a greater magnitude, because you don't want to anesthetize the teeth. You only want to anesthetize the gingiva. The main problem what happens is when you do that, if there is a risk, or what happens is, say the T.A.D goes and hits the root of the teeth, because we know that your radiograph is a two-dimensional image of a three-dimensional structure. We do not get to know exact location of the roots. We just get an idea of where the roots are placed, and sending the patient for a CT scan for T.A.D placement is unnecessary. We don't want to expose the patient to so much radiation. So just using your lateral cephalogram, OPG, good proprioception, good planning would be enough. And just in case the T.A.D tip hits the roots, we can change the angulation of the T.A.D and place them again. That's it. You don't have to do anything else, and hence you'll get a good result. But if you give a block, you anesthetize the teeth, the patient will not have any sensation. The teeth will not show, the teeth may show some amount of movement when you hit the root, but then the patient will not have any sensation. So if your patient does not tell you, you will not know where you're going. You need some amount of feedback from the patient, and if you're giving a nerve block, you're losing that feedback. That feedback is golden, and we don't want to lose that at any cost. So these are the things, extra things which you need for T.A.D placement. We know that we need a few extra T.A.Ds just in case, handy when you're placing it. We need constant irrigation. We have to, after you're given the LA and you have to start placing the T.A.D, you have to mark the location of the T.A.D. You have to mark the vertical and horizontal location of the T.A.D. By doing this, you'll get a intersecting point between the vertical and horizontal line, and that point is where you have to place the T.A.D in position. Now, when you're doing that, make sure that there's a constant irrigation so that you don't damage any tissue. So that's it for today. I hope you learned a few things about the armamentarium that's required for T.A.D placement, and how do you place T.A.D even if you don't have expensive motor equipment for placing T.A.Ds. Just the basic hand driver is more than enough, and it's a one-time investment. If you take care of the driver, I think it will serve you for a long time. I hope you learned a few things, and if you like this presentation, please like, share and subscribe. If you have any recommendations, please share them. I really want to improve the quality of this channel, and I want to improve the way this channel helps you in learning about orthodontics, in practical application of orthodontics. So if you have got any suggestions, any recommendations, please drop them in the comment section below. Thank you for staying till the end, and until then, keep learning.